If it's a cell phone, make sure it's on like silent.
Thank you. Thank you.
Sure. Feel sorry for y'all having to listen back to my voice. Hopefully, I'm loud enough. Did everybody sign in and grab a growth chart? You will need a growth chart for practice. Guys, if y'all need a restroom, you'll go out the back doors to the right and then to the right again. The restrooms are there. I leave it up to y'all. If you want to take a 10-minute break in the middle of class, we can. If y'all just want to get up and go to the restroom when you need to go to the restroom, that's fine by me too. It's kind of whatever y'all want. I'm fine with either. Any preferences? Just get up and go to the bathroom, no break, roll through. Okay. Look, I have another chair over here that nobody has a recording. And now I'm landlocked. I'm not moving. I don't know. There's no like clicker. I can't do anything. There's not a whole lot of room up here. All right. 8 o'clock. Let's get started. I am Miss Woodruff. Welcome to Level 3. I hope y'all have a great semester. I will be with y'all for this lecture, and then I have a mobility lecture that I will be back for. I am taking clinicals at the end of the semester, so if anybody is in my third rotation, I'll see you then. I don't even know what teams I'm talking to right now. None of you. Sorry. The team 2. But if you need me, I'm in my office, 4023. So come see me. I have chocolate, and I like to see y'all. So we are going to get started with pediatric assessment. Y'all have gone over assessment. You know adult assessment. So the purpose of today is to talk to you about the differences between adults and children. You will notice that my slides are not your slides, but we will talk about everything on your slides using questions and a lot of communicating back and forth, okay? This will be a whole lot less painful if y'all talk to me, all right? I don't like to talk at you. So let's get started. Welcome to Peds. If you're familiar with Grey's Anatomy, this is not general surgery in miniature or med-surg in miniature. These are tiny humans. They are children. They believe in magic. They play pretend. There is fairy dust in their IV bags. They hope and they cross their fingers and they make wishes. And that's what makes them more resilient than adults. They recover fast. They survive worse. They believe. In Peds, we have miracles and magic. In Peds, anything is possible. So our patients are not just little adults. These are totally different, and we're going to talk about what makes them so special and why you need to pay attention to certain things. There are some basic differences we're going to go over, okay? With kids, with pediatrics, the very first thing, the very most important thing is building rapport. Build your rapport with your families. Make sure that you have the right approach, okay? The more they trust you, the easier your day will be, and the more you'll get to know your patients, and that way you'll know when there's a change in your patient's status. Gain their trust early. In Peds, we practice atraumatic care. That is a term you will need to know. traumatic care. Everything we do, all of our interventions are going to be in order of least invasive to most invasive, least traumatic to most traumatic. If there is an option to do something that will cause this child less harm or less trauma, we're going to take that option first, okay? So least invasive first. Everything around them is strange and different. So when they're in the hospital, we're going to try and make them as comfortable as possible. If they're not on a strict diet, we're going to encourage the family, bring in the foods they're comfortable with, right? We want to make sure their home routine, if we can keep their home routine, we want to keep their home routine. We want to make this as easy for them as possible. Praise them for a good job. Every intervention you do, good job, you did so well with that. Thank you so much for letting us do that. Just praise goes a long way. Remember, they don't have much medical history, okay? So you'll see more injuries and more acute illnesses in the hospital, less chronic, okay? The differences that I list here, these are on page 114. Oh, your Peds book. I know I missed this discussion yesterday in orientation, but which version of your Peds book do you guys have? Of course you do. And we have the 8th. So my page numbers are for the 8th. So I'll have to update y'all with your page numbers for the 7th edition. Because these are on page 114 in your 8th edition. So let me get you, ignore my page numbers for your Peds books. I apologize about that. But we'll still go over them here. So children are smaller, okay? They have a larger body surface area, which increases their risk for rapid changes in body temperature and hydration. They also have an increased risk of toxin absorption through their skin. They have a faster metabolic rate. What does that affect? Their metabolic rate. The drugs, right? So how fast the drugs are being absorbed, how fast they become effective. Our drugs are also weight-based. So if you are not good at calculations, we're going to go home and we're going to practice these because we are changing everybody's weight from pounds to kilograms, and every medication you give will be dosed on kilograms, per kilograms. We're going to go over a few of those today, okay? We're going to go over how to convert pounds to kilograms, ounces to pounds to kilograms, because everything you're going to do on this level is going to be weight-based. They have a very immature immune system, so what does that put them at risk for? Infection, okay, especially your babies. And then keep in mind they're smaller, so smaller airways. Increased risk for lung infections, increased risk for airway obstructions. And then an immature blood-brain barrier and immature kidneys. Their kidneys are not working at optimal level. They get rid of things they're not supposed to get rid of. They hold on to things they're not supposed to hold on to. This is going to affect our medications. It's going to affect our hydration status. It's going to affect our electrolytes. Babies are very sensitive to sugar and salt, okay? So those are a couple of the key changes. Now, we're going to get into some scenarios where I'm actually going to present a patient to you, and we're going to walk through how you're going to handle this patient, how you're going to treat this patient. But before you go into anybody's room, what do you need to do? Before you go into anybody's room, wash your hands. What else? Get all your supplies. Be prepared. Look at your chart. What are we looking at when we're looking at a chart? What are they here for? What's their HPI, right? What's the history of their present illness? Why are they here? What's their history, period? In babies, in young babies, what's a big part of our history? Birth, preterm, okay? Gestational history, mom's history. So in young babies under 2 years old, we're going to want to know, were they full term or are they premature? Did they have it? Did they have to stay in the NICU? Were there any problems with prenatal history or birthing history? Did they have to go to the NICU? Did they have respiratory issues? What else is important in these young babies and young children? Wait. Shots, immunizations. Are they up to date on vaccines? Okay, we're going back to the chart we were looking at. You said you wanted, what else do you want to look at in the chart? What do you want to know? Allergies. Do you think we're going to see a lot of allergies in young babies and young children? No, because what do you need in order to develop an allergy? You need exposure. So this is going to be very important for us as we're giving first-time dose amoxicillin or penicillin, second-time dose penicillin. When are we actually going to see the reaction? First time? No, you need the exposure. So when would you see the reaction? Second or third, right? So that's going to be very important. Talking to the parents and saying, have they had any medications before? Do they have any allergies that we are unaware of? Or have they never been sick before? And that's what you're going to see a lot in peds. Okay, what else? Somebody said gather your supplies. What are your supplies? Stethoscope. Blood pressure cuff. In peds, you need to make sure you're using the right size blood pressure cuff. I have a chart in a little bit that's going to show you all of the locations where you can get a blood pressure on a baby, on a pediatric patient, okay? What if they have an IV? IV flushes, tape, guarantee you, babies are trying to get out of that tape. You want to bring some reinforcement. What else in the chart? Meds, IV, PRN meds. You're going to walk in, your baby's sick. You're going to say, okay, well, we've got a fever. The last time we had Tylenol was 2 hours ago, so I can't give that, but I can give Motrin. Or, okay, we're in pain. I can give this for that. You want to be prepared. Again, this helps you build rapport with the family. If you walk in and you know what you're talking about and you're not asking them all of these questions that are written for you, they're going to trust you a whole lot more, okay? So we're going into the door. We're prepared. We have all of our stuff. We know our chart. We know which patient we're going to see. How you enter in this door? You're going to knock. Like that? No, this is 7 a.m. and that might be a sleeping baby in there. And if you have just woken a sleeping baby after they've been up all night long, you think that mom's going to be happy with you? No, so we are very quietly. Hi, good morning. I'm Mia. I'm going to take care of you today. Okay? Everybody understand? I know that we want to introduce ourselves and announce ourselves, but 7 a.m. we're going to be respectful of that environment. So we walk in and we see 4-month Eleanor. She's in the hospital for bronchiolitis. Do y'all know what bronchiolitis is? Inflammation of the bronchioles, right? So it's a respiratory issue. You receive a report. You're performing your initial exam. When you walk in the room, she's resting quietly in mom's arms in the rocking chair. Everybody good with that? Okay. So we start talking. What is it that you might want to talk to mom about as you're observing little Eleanor? How was last night? How's our status? Are we improving or are we worsening? Right? Definitely important. Use the family as a resource. I've never seen this kid before. I have no idea if that is your normal color, if that is your normal appearance, if this is your normal behavior, right? So use the family as a resource. Okay, you talk to them. You want to find out about family history, family dynamics. These are all very important things when it comes time to discharge and possibly needing help with getting medications, or if this is a change in life. Do you have the resources you need? Do you have the family support? Do you have 3 other kids at home that no one is there with and you're stressed to the max? So talking to mom about some of these things, getting that birth history if it's not already documented, finding out how are we eating or drinking? What's our food status here? How are we sleeping? How's everything going? Now, this is little Miss Eleanor, and we have a teenager later in the slides, but if this was a teenager, some of our history questions are a little bit different, right? We're not talking about vaccines and prenatal history. We're talking about teenage things. So there's actually a slide in there about the Peds Assessment, and we will get to that later. But I just want y'all to understand that our information gathering changes as these children change in age, okay? First, under 2 years, we're talking about prenatal history. 3 to, 8 or 10, we're talking about, are they in daycare? Are they in school? Are they around? What's their environment? Then we get into these teenagers, and we're talking about a whole nother history, okay? So our history and our questions are not going to be the same throughout even this population of kids. So you're looking around the room. What are we looking for? Is Eleanor on oxygen? Are we attached to anything? Do we have an IV pool? Is there anything mom could trip over? Because our environment needs to be safe for mom and baby. Eleanor's not walking, but if this was a 2-year-old, is the trash overflowing and our 2-year-old is getting into the trash. Your environment is your responsibility. If that patient falls or that mom falls on your watch, that's your responsibility. So make sure you're checking your environment. Make sure you get in that room and you're looking. Okay, she is on IV fluids. When do I need to get a new bag? When do I need to reset this pump? When do I need new IV lines? That keeps you on top of it for the whole day. That's going to make it so much better. Mom's not having to call you saying, we're beeping, we're out of fluid, all these things. Make sure you're being very observant while you're talking to mom. Now, what about Eleanor? You're talking to mom. What are we observing on her? How she's breathing. What would be concerning? Accessory muscles. So babies do breathe with their stomachs, okay? But if they have retractions, do y'all know what retractions are? So retractions meaning if you can see their ribs and they're breathing. The higher up the retractions go, the worse we are, okay? So if we've got intercostal retractions, okay. I don't like it, but okay. Supraclavicular, I don't like it, but I don't want it to get worse. We need to do something about this. Nasal flaring, really bad. We need to notify somebody, okay? Head bobbing, she's not dancing. She can't breathe. Head bobbing is bad. And especially if you hear a whimsical kind of musical noise coming from her, she's about to stop breathing. So retractions, as they increase, they're bad, okay? So we're checking. How is she breathing? I say she's resting comfortably in mom's arms, but can you see that through a gown? No, we're going to have to lift up that gown. But we can watch. Are her lips dry? Does she look pale? Does she look cyanotic? Does she look hydrated? We can check. We can be looking at all of this stuff while we're just talking to mom. Now we're ready to perform our physical exam. What do y'all want to do? What do you want to do first? You want to move her? No. You want to leave her right where she is. She is comfortable in mom's arms. She is not terrified of you. And she won't be screaming, hopefully, if you just leave her right where she is. So what's the least invasive thing you can do for her? Listen with your stethoscope. Okay? So you have observed. That's the least invasive. Now you're getting ready to start listening. You have to listen for heart rate and respiratory rate. You cannot trust a machine, and you cannot trust your eyes counting. Babies and children move too much for you to just be watching and thinking you're getting an accurate respiratory rate. You do need to memorize, and they are different from your book, but your vital signs. These are the most up-to-date PALS vital signs that are in your notes. You need to have them memorized. You will be asked, test questions will be presented to you, giving you vital signs, and you will need to know, are these normal, are these abnormal, are these concerning? So your vital signs are a must memorize. So you're listening. While you're listening, what do you think you could do for Eleanor that may help you out? What's that? Warm up the stethoscope. What else? Distractions. Okay? Give her something to play with. Don't let her put your stethoscope in her mouth, because that's what all babies want to do, but that's probably pretty disgusting. But give her something to distract her. If she takes a pacifier, great, give her the pacifier. If she has a toy, ask mom, hey, do y'all have a rattle or anything in here? Is there anything we can use? If not, this works as a great toy. Great distractor, okay? So help distract her, help you be able to get a better exam. So you listen to her heart rate, you find a good place to listen to that heart rate. You're not listening for abnormalities, you're not listening for rhythm, you're not listening for any of that stuff. You are just listening for the rate. We will then move our stethoscope along and find any murmurs or abnormalities, okay? Again, same thing with respiratory rate. You find where you can hear it well, and you stay there. You count your respiratory rate. Then you can start listening for abnormal or adventitious breath sounds, okay? So
when you're checking for the rate, is it like taking a pulse for peds? You have to take it for a full minute?
Yep, good luck. If they give you a full minute, you go for it. It's great. If a baby is sleeping, Take advantage of that time. Don't walk out of that room and tell your clinical instructor, oh, they're sleeping, I'll come back. Absolutely not. Turn your butt around and get back in there. That baby's sleeping. That's the easiest exam you're going to get. You may not be able to do everything. You're definitely not shining your pen light in that baby's eyes, but you will get the best vitals you're going to get and the best exam you're going to get on a sleeping child. Okay? So don't say, oh, they're sleeping, I'm going to come back. You can do least invasive things while they're sleeping and not even wake them up. Okay? But yes, if they're awake, I count for 30 seconds and double it. If they give you a full minute, keep going. But keep that 30-second number in your head just in case you have to double it. Okay? So, head to toe. Well, let's listen. I want to see if y'all can count. We're going to practice this here, if this works. If y'all can hear it. Where is it? Where'd it go? There it is. All right. We're going to practice listening and counting heart rate. Everybody ready? Hopefully it's as loud as possible. Oh, I got to time you. Hold on. Let me get my timer ready because it's only a 28-second loop. It's not even a good enough. All right, I'm going to give y'all a full minute, if possible. Might only give you 15. Let's see. All right. Y'all want me to do it again for another 30 seconds? Okay, it's fast. Hold on. But that's what you're going to hear with a respiratory rate going along with that. So, Isn't that so much fun? Okay, let's see. Start. What'd y'all get? 72. So that would be one. Do the math. One. Thank you. 114. 144. 144. I'm like 114. That's not right. 144. But that's how quick that newborn's heart rate. Up to 2 months. That's how fast they are. And then you also have possibility of.
Sound of a waste, the high pitch continuous music.
Don't talk. Just play
This
it.
is caused by air passing through an obstructed narrow airway.
Stop. Where is it? There.
Classic wave may be referred to as a sibilant wave.
So on top of that heart rate, you'd have to do that. Or crackles.
Crackles are also known as alveolar rhythms. Sound crackles.
Those aren't as good as these. Let's see.
Crackles. This is how it is heard.
Everybody familiar with crackles?
Positional change are course.
If you've never heard adventitious breath sounds, YouTube is your friend.
Please.
Wheeze.
This is how it is heard.
Y'all heard that? It kind of sounds like a whistle. Okay. So you are listening. You are listening for. Shh, go away. There we go. You're listening for that heart rate. You are listening for your respiratory rate, and then you will move your stethoscope and listen for murmurs, regular rate and rhythm, and then you'll listen for your adventitious breath sounds. Okay? you do need to listen anterior and posterior because it may be different. If the babies have been laying on their back, you may hear something different posterior than you hear anterior. Okay? All right, so what else? Let's get to our head to toe. You've done your heart rate, you've done your respiratory rate. What's next in order of least invasive to most invasive? You can listen to, you auscultate your stomach. You've got your stethoscope on, so go for it. Auscultate your stomach. Then what? Start touching. Start touching your baby. What is it that you need to assess on a pediatric patient under 2 years of age, 18 months of age, that you do not have to worry about for anybody else? Fontanelles. Do y'all know what fontanelles are? They are the soft spot on the top of the head and the back of the head. Okay? The posterior fontanelle should close by 4 months of age. By 4 months of age, this posterior fontanelle should close. Anterior fontanelle can stay open until 15 to 18 months. Okay? Most of them close around a year, but it can be open that long. It is normal. Does anyone know what a normal fontanelle is? So you don't just write down normal fontanelle. What do you write down if you're describing a fontanelle? Soft and flat. Soft and flat. So a soft and flat fontanelle is your normal. Do not write normal. Write anterior or posterior fontanelle, soft and flat. Okay? Is it okay if you see it is pulsating? Yes, it is. Totally fine. You could see a baby's heartbeat on their fontanelle. Okay? Mine freaks people out because my youngest is, I don't even know how old she is right now, but hers is still open and you can still see her fontanelle pulsating. Okay? So that is normal. What is not normal? Sunken. What does that mean? Dehydrated. What else? What's not normal? Bulging. What's that mean? Increased intracranial pressure. A bulging fontanelle, increased intracranial pressure. A sunken fontanelle, dehydration. A normal fontanelle, which will never be written, would be soft and flat. Okay? Your book says that we are measuring head circumference until 2 years of age. CDC and most hospitals measure until 3 years of age. The growth charts have the head circumference until 36 months. So we measure until 36 months of age. So it's on your slide as 24 with an asterisk because your book says 24 months, but most national, like AAP and all those, recommend until 36 months. 36. Because nationally recognized, it would be 36. So follow this national standard of practice, 36 months. Okay. Sutures. So the sutures, y'all know why babies have fontanelles? Because you need space, right? They need to be able to grow. And if you come out with all of your bones, your skull fused already, then can their head grow? No. So babies may come out with, it's called overriding sutures, and that's when actually the bones are overlapping. But they will go ahead and form. There's a whole bunch of cranial deformities that we are not learning, but head circumference is one way of helping us to know, is the baby growing? Is the head growing like they should be? What's next? Moving on down. Eyes, taking note of the eye position, taking note of their pupils. If this is a sleeping baby, do we expect you to go and shine your light in their eyes? No. Most pediatric patients, you do not have to use your pen light unless, what's the one caveat where you will always shine your light in their eyes? If there is a neuro problem. So if this baby is in there, shaken baby or some specific neurologic issue, you will do that as part of your focused neuro exam. Okay. Ears. You will not be using an otoscope and checking in patients' ears. But if you had to, do you know how to position their ears so that you can get a good visual? Back and down for how old? Under 3. So under 3, you pull back and down. Over 3, you pull back and up. Okay? So under 3, back and down, over 3, back and up. Nose. What are we worried about with her nose, with baby's nose? What are we looking for? Patency. Is there nasal congestion? If she is having trouble breathing, the very first thing we're going to do, the least invasive thing we can do, is get rid of any kind of nasal congestion. What else are we taking note of with her nose? Is she having nasal flaring? That would be a bad sign. Mouth. What are we looking at? Color. Cyanotic would be one thing. What else are we looking at with her mouth? Thrush. Moist or dry. We're looking at hydration status. With her, now this baby, she doesn't have teeth, but when do we expect kids to get teeth? 6 months. Anywhere between 6 months and a year, they should be starting to get teeth. Why is it important that we take note of teeth? If we have to intubate and there's a loose tooth or a missing tooth or whatever, we want to make sure, oh no, that tooth was never there, or yes, there was a tooth there. I am not going to ask you. You do not need to know the order in which the teeth come in and the order in which the teeth fall out. But you do need to know around 6 months of age, we may start seeing teeth, and around 6 years of age, we may start losing teeth. Okay? Moving on down. We're looking at all of their skin color, yes. Then we're looking at their chest. We've already listened to their chest. That you should have lifted up the gown or shirt or whatever they're wearing to make sure and get a good assessment. Okay? You have pictures in your slides. There are a few things to take note of. Eleanor, maybe not so much, but an older child. Your pectus excavatum, that funnel chest, think of an excavator. The chest has dipped in versus your pectus carinatum, pigeon chest. Now, if y'all are in the 7th edition, your book has this wrong. They have them flipped. So make sure you know excavatum, like an excavator, it's dug out, sunken in, and carinatum, like a pigeon chest, pokes out. The other thing in babies that can be normal on their abdomen, what is it? An umbilical hernia. We do not do anything about an umbilical hernia unless they have not gone away by the age of 5. We give their abdomen time to close on its own. We do not take these kids to surgery. So for an umbilical hernia, are we telling the parents, go ahead, tape it down? No. Are we telling them to do anything with it? No. Leave it alone. What do you need to do as part of your assessment if you see an umbilical hernia? You need to push on it and make sure it's retractable. You need to make sure it does go down without any problems. Because what if it doesn't? It is exactly. So it does not go down. And what is a hernia? What's inside of that? Intestines. Right? So if the muscle has now closed and the intestines cannot go back in, what are we worried about? Loss of circulation and then tissue death. So you do need to easily push down on it one time. It is fun because they're soft and squishy. But don't continue to push on it. You can bruise the baby's skin, and then the parents are going to freak out that now it's blue. Is it okay? Yeah, you played with it too much. But if the child is screaming, do you think you'll be able to push that umbilical hernia down? No, because they're using their abdominal muscles, so now they're pushing it out. So when the parents say, oh, but every time they cry, it gets bigger. Well, that's normal. Okay? So umbilical hernias, we watch them, we monitor them. They are very common, and we don't send them to surgery until they're about 5 years of age. Okay? Moving on down. Pulses. Where do you check peripheral pulses on young babies and little pediatric patients? Where are your peripheral pulses? Brachial. So your brachial pulse, right? And then as they get older, then you can start checking radial. But young babies, brachial pulse. Where else? Pedal's pretty far. Let's try closer. Femoral. So you're checking femoral pulses on young babies. So when you go to do your assessment of their diaper area, it's a great time. You frog leg this baby, and you will check their femoral pulse. It's very easy. Y'all know what frog leg means? Okay. So you check their femoral pulse right there with a frog leg position. When you're checking their femoral pulse, Do y'all understand you're actually checking upper extremity versus lower extremity? You're not checking right versus left. You're checking, does the right femoral pulse match the radial pulse on the right arm? Okay? If it does not, there is a problem where? In the aorta. Okay? So you're checking your femoral pulse. It should be 2+, just like your brachial pulse. Okay? Now, we're checking diaper area. We're looking for what? Rashes, skin breakdown, anything like that. If this was a boy, what are we checking for? Circumcision. Are they circumcised? And if it's a young baby, is it healed well? What else? Testicular dissension, okay? Making sure you feel 2 testicles. Now, they can continue to go up and down until about 12 months of age, but you should be able to put a little bit of pressure there and get that testicle to drop and feel 2 testicles, okay?
Do we need to get specific consent to look at a child's
No.
diaper area?
Nope.
It's just simply-
You just, if you're talking to mom as you do this, you just say, all right, mom, I'm just going to feel pulses real quick and just check the diaper area for diaper rash. But it is important, especially if this is your intake physical, that you take note of any rashes, bruises, anything. Because if it gets documented after that now the baby has a diaper rash, or now we have to, that's a problem for the hospital.
I
Okay?
don't know if, like, as students, we need to get, like,
No, you do not. You can talk to the parent. If they're awake, you could talk to them as you're doing an exam, as if they were the patient. And even young kids, you can tell them, if this was a 2-year-old or a 4-year-old, I just have to look down here real quick. I just have to, do these things. Now that you're not checking diaper area on a 4-year-old, but you can talk to your, a little bit older than Eleanor, patients as you go through your exam and let them know what you're doing. So if this was me and I'm doing an exam on one of my patients, I just tell them, look, I just have to feel your heart rate, or heartbeat, because they don't know what pulses are. So I say, I got to feel your heartbeat here and here, and I just have to take a quick look and make sure everything looks normal. And they, okay. Now, on baby Eleanor, there are a few things that that we need to check as well. What is specific to newborn and infant and young babies? Reflexes. Reflexes. Your book has a chart. This one is actually in your concepts book, so the pages should be correct, and it's not even in your pediatric chapter. It's in your newborn chapter for OB. But it's table 3316, page 2385 and 2386. You need to know these reflexes. So let's go over them. Babinski. Who knows how to elicit a Babinski? Stroke their foot. What happens when you stroke their foot? Their toes should flare out. That's a positive Babinski. That's normal in a newborn. It's not normal in older people. It means bad things in older people. But in a newborn, you elicit the Babinski. Their toes flare out, right? You stroke their foot. Their toes flare out. What's the next one? Tonic neck or fencer position. It's named fencer position for a reason, guys. So babies take a position of comfort with their arm out. And when you turn their head towards their arm, their opposite arm comes up like a fencer. So they're like a fencer. Tonic neck, okay? So arm out, head turned that way, and this arm, opposite arm, comes up like a fencer position. Palmar grasp, pretty easy. How do you get a palmar grasp? Put your finger in their palm and let their fingers curl over yours. Same thing with their toes. You put your finger by their toes and their toes will curl over. That's a positive palmar grasp.
Do we need to, see the strength? Or, because I know, some people, they, make them grab their fingers and they lift
That's different. That's checking their neck. So they should have head lag. So when you grab a baby's hands and you pull them off the table and they have head lag, you're checking their neck strength. That's not actually palmar grasp. Okay. Sucking. How do you get a sucking reflex? No. Not stroke their cheek. Sucking reflex. Put your finger in their mouth. Put your glove on. Put your finger in their mouth. That'll check a sucking reflex. What's a positive sucking reflex? They start sucking. Okay? What else can you do while your finger's in there? What else can you be checking?
check the soft palate.
Check the palate. See if there's any kind of cleft palate, which you'll learn about with Dr. Clerk very soon. But you'll check the palate, okay? So sucking reflex, you put your finger in their mouth, and they start sucking. Rooting reflex, stroke their cheek. And what's a positive rooting reflex? If they turn their head towards that, they should start trying to eat. Stepping reflex, what's that one? You hold them up on top of a table and they start moving their feet as if they're walking, taking steps. That is just a normal newborn reflex, okay? So those are the ones your book specifically lists that you need to be familiar with. You need to know what a positive sign is, how to elicit it, all those things. Oh, Moro, I skipped over. What's Moro reflex?
Whenever you set them down, they go like out and startle up.
Okay, so it's startle. So they could be laying there and you make a loud noise, or you do a palmar grasp and kind of see how, lift them up off the table and drop them back down. And then what's a positive startle? What's a positive Moro? They literally startle. It's not a seizure, it's just a startle reflex. And you can remember Moro because any moron can startle a baby. Okay? So Moro reflex is the startle reflex. They jump. Warn parents, it's not a seizure, it's not anything concerning, it's a normal newborn reflex. So I told y'all earlier, we've now done our assessment, and then we leave some certain things to the end because this is going to make the babies cry. Okay? Blood pressure. Blood pressure is going to make the child cry. Do it at the end. So you could take a blood pressure, all these different extremities on kids. The most common place is going to be lower extremity. That will be the most common place. As the child gets older, you could try upper arm and do your normal blood pressure, but obviously make sure you're using the right size blood pressure cuff, depending on where you are checking their blood pressure. Here are your vital signs. These are a must memorize. Be familiar with them. You need to recognize normal so that you know abnormal. And you know, okay, that's a low blood pressure, that's a high heart rate, that's a high respiratory rate, whatever the case may be, and I need to do something about it.
What was the fourth place to take a blood pressure on?
Upper, lower, upper, lower. Okay, y'all memorize those. Pews. Anybody know what a Pews score is? Pews system. So there is a NEWS and a PEWS. These are pediatric early warning system. NEWS would be neonatal early warning system. But this is another objective way for us to monitor our patients and say, something isn't right, but I don't exactly know what's wrong. Well, we have specific characteristics and a scoring system that helps us figure out we're trending down and I need to do something about that. So in your hospital, you'll actually see a card like this. And on the back, it tells you what to do depending on your Pews score. Majority of the time, your Pews score is going to be 0. Majority of the time, you don't even need to think about this. But if you start to notice, my vital signs are trending downwards and I don't really like it, the patient is becoming more fussy or inconsolable, and my heart rate is changing, my respiratory rate is changing. Let me get another objective way to monitor this so that I can inform the doctors that I did start with a Pew score of 0, and now I have these vital signs and this Pew score of 1 or 2 or 3. Okay? So a 0 to 2, you don't really do much about. You don't do anything. You continue to monitor, and then as the Pew score increases, you're going to follow your algorithm and talk to your provider about what do we need to do here. So as far as a Pew score, you may say, okay, my heart rate is 20 beats per minute higher than normal, but my respiratory rate is within normal limits, and my patient's fussy. What's that a Pew score of? But patient's fussy, heart rate's elevated higher than 20 beats above normal, and my respiratory rate's within normal limits right now. That's a Pew score of 2. So you add up your individual. You would give the patient a 1 for behavior, a 1 for cardiovascular, and a 0 for respiratory. Okay, so that would be a 2. Do y'all understand that? You do not need to memorize this chart. If you hear a question or see a question about a Pew score and someone is asking you to score your patient's status, you would have the chart as a reference. Do not memorize this, but understand how to use it. That makes sense? Okay. How do we know if a baby is hypotensive? Well, there's a calculation for that. The first of many we're going to do today. So, for your babies, for your 0 to 28 day old, term neonate. What's that mean, term neonate? 38 weeks or more. They went to term, but understand what term means, right? So 38 weeks or more. If they have a systolic blood pressure less than 60, they are hypotensive. If they're 1 month to 12 months and have a systolic blood pressure less than 70, they are hypotensive. From kids 1 to 10, 70 is kind of our baseline, and we're going to add on from there. So we're going to use their age, multiply it by 2, and add that to 70. And then that would be our baseline. So if I have a 4-year-old, a 4-year-old would be considered hypotensive if their systolic blood pressure is less than 78. If it's a 6-year-old, they would be hypotensive if their systolic blood pressure is less than 82. Makes sense for everybody. We get all the way up to 90, and then anyone 10 and under, less than 90 systolic, would be hypotensive. Because 10 times 2 is 20. 20 plus 70 is 90. So anybody above 10, less than 90 systolic blood pressure is hypotensive. Does everybody understand that? Okay. I think y'all have the example. All right, so little Miss Eleanor, you're doing your exam. You get these vital signs. What do we think? Look at her blood pressure. She's 4 months old. So what would be a hypotensive blood pressure for Eleanor? Less than 70. So we're at 82 over 68. We're okay with blood pressure? We're good with it. Heart rate, 128. She's 4 months old. We're good with it. Okay. Respiratory rate, 78. A little high. Yeah. Yeah. Temp, 100.9. What do we think? It's a fever. What is your threshold for fever? 100.4. I don't care how old you are. I don't, that's the national standard. That's the hospital standard. 100.4, you have a fever. So 100.9, what are we going to do about that? We're going to treat it. We're going to see if she's got some PRN orders in her chart, and if she doesn't, we're going to contact a physician, and we're going to treat it. What are we going to treat it with? Tylenol. She's too young for Motrin. Motrin cannot be given to children under 6 months of age. Tylenol only for this little one. And Tylenol comes in all forms, PO, IV, and up the booty, rectal. Okay? So, her pulse ox, what do we think? 95%, not great, but we also have a respiratory rate of 78. So what do we want to do first for Eleanor? Least invasive intervention we could do for Eleanor. Okay, so first thing we could do is reposition her. Make sure she is upright. Give her optimal breathing status. Second thing we could do is check her airway. Is she full of congestion? Do we simply need to suction her out? That goes a long way with these little ones, okay? So, we check. How are we going to suction Eleanor? What can you use? What are your tools? Bulb suction is one. What else is in the hospital that you have great use of? The wall suction. And it's actually a neo-sucker. So it looks kind of like a 1 mil syringe, and it goes straight up the nose. Okay? It is not a big old yanker suction. It's just called a little neo-sucker. It's very skinny, goes right in their nose, sucks everything right out. The kids hate it, but then they can breathe. So we make them mad for a minute, and then they can breathe. Okay? So if the bulb suction's just not doing it for you, get that wall suction. Get it right out. And then you see, did we improve her respiratory rate? Now look, if you just made her cry, you got to give her a minute before you count that respiratory rate again, okay? Let her sit back with mom, let her calm down, check her respiratory status again. Check her pulse ox again. If we improved it, do we need to do anything else? No. If we didn't improve it, if we still see nasal flaring or supraclavicular retractions, or we still see a pulse ox of 95 or less, what do we need to do? Listen to her, get a good assessment, then what? Report it to who? You are the nurse. The physician. Let the physicians know, look, we've got a status change. Can you put oxygen on Eleanor? Without an order? No. Oxygen is a drug in the pediatric population. And I know in emergency situations, y'all are going to find a reason to slap oxygen on a baby, and that's fine in an emergency, but this is not an emergency. So when you're standard hospital care, you are not just going to put oxygen on a child. You need an order for it, okay? And are we starting at 2 liters per minute? No, we're starting way low. We may even start at a percentage. We may not even give them a full 100% oxygen, okay? So pediatric patients, you don't need to know the ins and outs. Just know we start low, we go slow, and it is a drug. You need an order for it. All right, so what are we going to do? We've got Tylenol orders. You check your chart. You've got a Tylenol order. It's not well-written order. Ready for a calculation? It is 15 mg per kg. How are you going to calculate that and administer that to Eleanor? Her weight. Good, you need to know that. She weighs 11 pounds, 12 ounces. $15 mgs per kg, 15 mgs per kg. She weighs 11 pounds, 12 ounces. Somebody walk me through it. What's the very first thing you need to do? Convert what? Ounces to pounds. Very first thing you need to do is convert ounces to pounds. How do you convert 12 ounces to pounds? 12 divided by 16, because you've got 16 ounces in a pound. So you need to, very first thing you do, divide 12 by 16. What do you get? 0.75. So now you've got your patient who weighs 11.75 pounds. Now what do? Convert to kilograms. Divide by 2.2. And what do we get? Exactly, 5.34 kilograms. Does everyone understand how we did that? You cannot just say that Eleanor is 11.12 pounds. She's not. 11.12 is very different from 11.75. And when we're dosing everything based on weight, that is important, okay? Because we may not give her enough medication or too much if we're converting incorrectly. So we've got a patient who weighs 5.34 kilos. What's our dose of Tylenol?
In Farm 3, so when we convert to kilos, we're supposed to keep up to the tenths. Is that how we're doing it?
I love Farm 3.
Well, she said, I thought it was like according to her question. Like she would put behind her question.
It was the standard.
Okay, so I'm going to tell you this. For nursing 3, do not round anything until the very end. When you get a weight, you round to the hundredths. And at the very end, then we round. Okay? So I don't care where you are in the middle of your conversion, don't round anything until the very end. And when it's time for it to actually answer the question, you will be told, give us your answer to the tenths, give us your answer to the hundredths, give us your answer to a whole number. Does everyone understand that? Because we get a lot of questions about what does this mean. If it says whole number, there's no decimal. Round to the whole number. If there's a tenths, it's the first number after the decimal. Hundredths, second number after the decimal. Okay? And it will tell you on your question, round your answer to the whole number, tenths, or hundredths. So for Eleanor, what's our recommended dose? 80 milligrams. So for this, it would have been round to the whole number because you can't get 0.1. So 80 milligrams, okay? Everybody got to 80 milligrams? If you have any questions, come see me after class. All right, moving on. That was the longest scenario. We have 3 more we're going to fly through. All right, so now you're on the unit and you get report from the emergency department about a 23-month-old little Oliver who has cellulitis on his butt. It's awful. The nurse tells you he has been crying since he got there. He has an IV, but he needs his IV antibiotics. So, you go in, you do your initial assessment. Oliver is screaming, crying. You going to do a full assessment on Oliver? No, but you are going to do a focused assessment. Good luck. But what does every focused assessment include? Respiratory. What else? Cardiovascular. What else? So observing, but that's cardiovascular, skin color, all that stuff. Respiratory status, cardiovascular status, and I heard somebody else say it. Neuro. Are they awake and alert at baseline? Okay. Now, I love it when students tell me they're oriented times 3 or 4. Really? Little Eleanor's telling you she knows where she is and her name? No. So when you say like awake and alert and oriented, just put awake and alert for a baby, okay? Or if she's sleeping, put laying in crib or laying wherever with eyes closed, resting comfortably. But don't tell your instructors that your 2-month-old is oriented times 4. Okay, so you do your focus assessment for Oliver. Now that's on everyone. Everyone's focus assessment includes neuro, cardio, and respiratory. But for Oliver, what else is included in your focused assessment? His butt. What is going on with this cellulitis? You've got to look. He's going to be mad at you no matter what. So get it done. Sorry, friend. Look at that diaper area. Hopefully someone has already drawn a line around the cellulitis. Do y'all know what cellulitis is? Y'all have gone over cellulitis. Okay. Hopefully somebody has drawn a line around that cellulitis, but you need to also take a look at it for yourself so that you know and you can document. At my initial assessment, this is what it looks like, and this way you can also report it off to the next nurse or whatever. Okay? So you do your vital signs, you do your initial assessment. This is a new admit. So as angry as he is, we need to get a few things that are very important. What do we need to get? Well, his vital signs. What's included in vital signs on an admit? That's on everybody. You want a new admit? That's on everybody. No, vital signs. His height, his weight, his head circumference. So how are we going to check a 23-month-old height? How do you check a height on a baby like that? Lay him down. Y'all have a picture. There is a scale. A laying flat board. You lay that baby on that flat board and you get a height. Now, let's say he's 23 months old and he's not screaming, crying. How do you check his weight? You got a couple options here, but we're going to stick, 23 months old according to the book. How do you check a 23-month-old weight? Sit him on the scale. Sit him on the scale. Lay him on the scale. You are not putting him on one of those standing scales. Over 2, 3 years old, 4 years old, you can pull up the standing scale and they can get on the standing scale. But for a baby, for a young child, we're sitting them on the baby scale. Y'all have all seen the baby scale at the hospital? Okay. Are you going to, Oliver, stay right there. I'll be right back. No. Absolutely not. Are you even going to do that to Eleanor, who's only 4 months old, and you don't expect her to roll? But are you leaving a child on a scale? Never. Your hand will be on that child the whole time. You lift it up, you get a weight, but you're standing there like this, ready to pounce. Okay? You don't ever walk away from a child on a scale. I'm telling you, a newborn will roll over faster than you, and you're like, you're not even supposed to, but they fall off. That would be a bad day. So, stay put. 23 months old, we also said we are doing head circumference. That's part of your intake physical, okay? So head circumference, height, and weight. Know how to use your scale. Know how to use the equipment and which equipment you're supposed to be using. That's important. Now, I said there is a sixth vital sign. Anybody know what it is? Pain. Pain. You need to know, again, how are you assessing this child's pain? So there are different scales we can use for pain, right? You've got your faces, you've got your flat scale, faces, and numeric. They're all broken down by age. So, flat scale. We typically use this for kids who are under 3 years of age. And do you understand how to use and score the flat pain scale? It's just like the pews where you're adding up per behavior, okay? So, if I told you, let's give you an example here. If I tell you Oliver has a quivering chin with a constant frown, legs are uneasy and restless, he is squirming frequently, he has a steady cry, but he can be reassured by mom hugging him. What's your pain scale? He has a quivering chin with a constant frown. His legs are uneasy and restless. He's squirming frequently. He has a steady cry but can be reassured by mom hugging him. 7. Does everyone understand how we got to 7? Okay? Again, you do not need to memorize the FLAC chart. If you have a question on it, you will be given the chart, but you need to understand how to add it up and get your score. Okay? As far as the Wong-Baker faces, we can start to use this around 3 up until they're adolescent. Okay? Around 3 years of age, kids can start to tell you, my neck hurts, meaning my throat. But they can localize their pain, my knee, my elbow, whatever. Around 3 years of age, kids can start to pinpoint where they're hurting and start to communicate that with you. So once they understand that system of looking at faces around 3 years of age, you can start to use the Wong-Baker faces. And then, like I said, for the numeric, that just depends on how old they are and how much they understand. So anywhere from 9, 10 years of age, maybe even as early as adolescence, you can start using the numeric. And that's the one that I think most people are familiar with, right? How do we control pain in kids? We're hitting them hard with some heavy-duty narcotics? No. There are different ways of controlling pain, right? So one way, non-pharmacologic way, is ice and heat. What else? Swaddling for infants and young babies would be great. Positioning, helping them getting into a comfortable position. Distraction. You will see in the hospital we have friends, child life specialist. Anybody know what a child life specialist is? I see some yeses. Anybody want to tell us what a child life specialist is?
It's a team.
Say it loud and proud.
It's a team that works in the hospital. They come around, cheer up the kids.
A little bit more than that.
More than that,
But yes, they are specialists who have a degree in early childhood development, and they know, okay, a child of this age may like this toy or they come by with developmentally appropriate distractions for our kids, okay? So if a baby is in there, say it's Eleanor, they'll come by and give us a, what's that thing called, a mogul for the crib, okay? Or rattles for her to play with. Or a sound machine, or one of those things with a whole bunch of lights, okay? For Oliver, they may come by with an iPad, or with trucks, or with dinosaurs, things for him to play with. For teenagers, they literally will wheel in a TV and an Xbox. Not even lying. But they are your friends. So if you have to do something invasive to these kids, you call Child Life and you say, hey, I'm about to start an IV. Hey, I'm about to do this. I'm about to do that. I have to give a shot. Can you come in and offer distraction? And they'll come on in with their little iPad and put on Bluey, and your kid is nice and distracted and doesn't really pay attention to you sticking them in the other arm. Okay? So child life specialists are your friends. So those are our non-pharmacologic methods of controlling pain. What are our pharmacologic? your NSAIDs, your Tylenol, if it is severe, okay, we've had some kind of surgery or trauma, we can use opioids. How old is the youngest we would offer a PCA? About 5 years old. That's the youngest. And that depends on their dexterity, their understanding. So that's not just like a standard, every 5-year-old gets a PCA pump. But as early as 5 is when they have enough ability to have a PCA pump. Okay. All right, so here's the next fun interactive part. These are your height, weight, head, circumference. These are your initial vital signs. Before we get into charting our initial vital signs, what do we think about our vital signs? I mean, before we get into our height, weight, what do we think about our vital signs? He's 23 months old. Blood pressure. We okay with blood pressure? Yeah, we're good with it. Heart rate. We okay with heart rate? It's okay? What's our max heart rate for a 23-month-old? 150. So we're 140. We're high. Okay. Respiratory rate. It's a little bit high. Tim. Fine. We're good with it. And pulse ox. So why do we think that little Mr. Oliver might have a high heart rate and a high elevated, higher than normal respiratory rate? He might just be in a little bit of pain. So let's give him some medicine. Okay? Before you give him any kind of medicine, what do we need to know? What are the steps we need to take to be able to give medication? Your 9 right. So you've got your typical 5, right? How are we identifying Oliver? Are you saying, hey, are you Oliver Payne? Because what's he going to do? You terrify me, lady. Get away. No. So we're asking who? The parents. Okay? I do love it when students come to me and tell me, well, the patient didn't verbalize anything. Or like, the patient didn't tell me blah, blah, blah. And I'm like, did you ask the mom about these things? So you ask the parents. If the parents aren't there, you wait till they are. Okay? What else? You can check name and date of birth on the armband, but you need someone to be able to identify your child. So parents are going to be your source of information. You've got to make sure it's the right kid, the right medication, the right dose, the right time, the right route, right? All those things. Right documentation. So make sure you are scanning it or documenting somewhere that you're giving it. Right approach, growth and development. So if this is Eleanor and we need to give an oral medication, how are you giving it? A syringe by mouth. Are you putting it right here? Because what's she going to do? Tongue thrust that medication right out. She getting anything? No. Back of the mouth, back of the cheek, all the way back here, so that when she does this, it doesn't matter because the medicine's back here in the back of her mouth. Okay? So all the way in the back of the buccal space. Now, little Oliver. And I know this is controversial, and y'all going to go, Miss Woodruff, what? Do you think it would be less traumatic for you to force him down and give him this medication, or say, hey, Mom, will he take this from you? What's the less traumatic way to do this? Mom. Hey, Mom, you think he'll sit on your lap and just drink this for you? You do not walk away. You don't go, hey, here's his Tylenol, I'll be back. No, that is not safe practice. You stay there, you observe. If he's not taking it for her, then I'm sorry, you do need to go into more invasive and more traumatic ways. But if you can avoid that trauma, you can then try to avoid the trauma. Okay? So right approach with growth and development. Right to be educated. What if Mom says, I don't want him having any medicine. We can handle the pain. Is that okay? Mm-hmm. It is fine. She can refuse the medicine. But what can you do? Educate. Mom, I understand you think that, or if it's a narcotic or whatever, you're afraid of them becoming addicted, or your family has a history of addiction. That's fine. Let's talk about it. What are your fears, and how can we work around this? So what if it's not a narcotic? What if we do this instead? So talk and have a conversation. But yes, the parents can refuse. Even older children can refuse. Okay? All right. So before we get into scenario number 3, let's plot. Get on your growth chart. And we're going to plot Oliver. Oliver has a height of 32 inches. I'm going to have to walk around for this because y'all don't really understand this. So on your growth chart, your length. You've got length on the side here. Right? Length on the side here. Length on the side here. Your age is up top. So you find 23 months of age right there in the middle. And then you go and find 32 inches. And you follow that line to where they intersect. 32 inches, 23 months of age, and you put your dot right there. Okay? So you find your length, 32 inches. You find your age, 23 months. You follow your 2 lines and put your dot where they intersect. If you don't want to do the extra step. What I tell you? 28 pounds? Is that what I told you? Hold on. I'll go back. Yeah, 28 pounds. Everybody over here got it? Okay, so guys, it's great that we're plotting this, but what does it mean? Did somebody say, I don't know? Well, that's why you're here. Okay, so why do we use growth charts? We're tracking them, right? We need to make sure they're staying on trend. So, one, we're comparing them to their peers. So that's what these percentages mean. So if you look at these small numbers in the middle of the lines over there, those are percentages. So all the way here on that left-hand column, these are percentages. 95th, 90th, 75th, 50th, 25th, 10th, and 5th. Those are your percentiles. Okay? So our patient is somewhere between 5th and 10th percentile for his height. Right? And then he is 50th percentile for his weight. That's a beautiful kid. Okay? Now, what would be concerning on your growth chart? If it is too low, what would be too low? Less than 5th percentile, right? Now, I said we are tracking them and we are watching trends. So if you have a small baby, like I had, 4 small children, tiny little bits, they are all under 5th percentile for their whole lives so far. Their head circumference is like, I don't know, less than 10th percentile. Are we worried about that? Because it's the trend, okay? So if we start at birth at 5th percentile and we get to 23 months of age and have maintained that curve of 5th percentile, am I saying this is a child with a problem? No, I am not. I am saying they are following their growth curve. How do I know if there is a problem? if we fall off, right? So if all of a sudden Oliver comes in at 30 months and we're down to 10th percentile, and we've maintained our height on 10th percentile, are we worried then? We sure are, because it's not like he's gone through a huge growth spurt that we can explain, okay, well, he grew upwards and his weight kind of balanced. No. He's maintaining his height as normal and his weight has dropped significantly. That's a problem. Okay, if we go from 25th to 5th or off the grid, that's a problem. We are monitoring trends with this growth chart. Does everyone understand that? Okay. So if you have a kiddo that presents to your hospital and you say, well, I'm plotting it on the 5th percentile, are you immediately saying they're failure to thrive? No. What are you saying you need to do? You need to either be able to get into their previous history and say, have they always been on their 5th percentile, or is this something new? You need to look at the history. Or you need to keep them long enough to see, can they gain weight? That's a different lecture. Anyway, everyone understand growth chart?
I have a question, just to kind of go back to the rights. What if the parent is not there? How do you go about?
Giving medications?
Yes.
So, depending on your facility, there's always someone that should be present with the child. Okay? Now, that's not going to happen. So, your test and your NCLEX, you're going to have a person there. In real life, you're asking me, and this is the first time you've ever met this child and there's no one there, you're trusting the nurse before you. Because at Ochsner, no, Children's. Ochsner requires a parent or a caregiver. Children's does not. So at Children's Hospital, if you have clinicals at Children's, you're going to have unattended kids. And so you're trusting that this is the kid that you're telling me this is.
Okay.
And yes, it happens all the time. Babies, young children, they're left. And guys, but don't think the worst of people. Don't automatically go, how are you leaving your kid? They may have 4 other kids at home and nobody to help them. And they come during the day, but they're not there at 7 a.m. You know, you don't know someone's situation. So that's a whole nother, that's a soapbox. But yes, in real life, you trust the nurse ahead of you. On a test and in a perfect world, there's always going to be someone. Okay? All right. That. We talked about side effects. We talked about... Okay, if you are given a pain medication, when are you reassessing? If it's oral, how long should it take? 30 minutes to an hour. You should see some effects. What if it's IV? 15. Okay. All right. So, but that is part of your assessment. You need to reassess and make sure, did we achieve the goal? All right. 3, and then scenario 4, and we're out of here. This is so great, guys. Y'all are moving right along. All right. You now have little 7-year-old Rory, which is a child, I never got to name it, one of my kids, Rory, admitted with diarrhea and dehydration. Rory weighs 55 pounds. You're reviewing your current vital signs and urine output. What do you think? First of all, what's a normal urine output for a kid? Everything is based on weight. So don't you think urine output's probably going to be based on weight too? 2 mils per kg per hour. Normal urine output, 2 mils per kg per hour. Definitely not less than 1 mil per kg per hour. Why do I mention that? Because that's going to change our interventions, right? So if we get a urine output somewhere between 1 and 2 mils per kg per hour, we can probably try and rehydrate orally or with a less invasive measurement, right? But if we get a less than 1 mil per kg per hour, I can almost guarantee you we're going for that IV. Okay? Because these kids cannot last long. Their kidneys do not work properly. So if we're getting less than 1 mil per kg per hour, you pretty much aren't. You got to go for that IV rehydration. Okay? But somewhere between 1 and 2, you may see the provider saying, well, let's try oral rehydration first. It's less invasive. Let's see if we can get them back up to where we need them. Okay? So, tell me, calculate. Your patient weighs 55 pounds, and I want to know what's our urine status. Are we normal? Are we optimal? Are we less than optimal? Y'all do some calculations. Let me know what you get. What's your normal? What is your urine output per hour for Rory? So that's what you would want him to be. You want him to be above 50 mils per hour. How did you know that?
Because I converted to kilograms and then multiplied.
How many kilograms did you get?
25.
There you go. And then you did what?
Multiplied by 2.
Does everybody understand that? So we convert to kilograms, we get 25. We multiply by 2, we get 50 mils per hour is our optimal urine output for Rory. What is Rory's actual urine output? For what I'm showing you here. What is our actual urine output for that 12 hours? Okay, so you got 270, but then what's your next step? That's the urine output over 12 hours. So 22.5. So we got 60 plus 120 plus 90. 270. That's over a 12-hour period. So per hour, we're at 22.5. 270 divided by 12. 22.5. All right, and we want 25. Huh? I'm sorry, you want 50. You want 50. A minimum 25. So what do we need to do? We're at 22.5. We're under 1 mil per kg per hour. So we need to call somebody and say, hey guys, we got no urine output on our little friend. Okay? Guarantee you, if they're here for dehydration, they're already on IV fluids. But for our scenario, we want to contact somebody and say, our urine output is not matching, and what do you want to do about it? Okay? So, yeah, 22.5 is definitely not acceptable, and unfortunately, we can't just say, well, let's push some oral fluids. The provider's probably going to say, start an IV. Okay? Now, you get your IV fluid order. Oh, well, wait. Before I get into the fluid calculations, how are our vital signs? 7-year-old Rory. How are we looking on vital signs? Blood pressure, what do we think? Okay, so we're okay with blood pressure. Heart rate. A little bit high. Respiratory rate. Any concerns? No? Temp, any concerns? No. And pulse ox 100%. Okay, so what would be our hypotensive, Rory? Less than 84. Systolic blood pressure less than 84. Everybody remember how to do that? All right, cool. So you get new orders. Now this is the part in the lecture where everybody gets confused, so stick with me. Unless I've already confused you. I'm sorry. Okay, so you get your new orders for IV fluids. Here's the formula that's going to help us determine if these orders are good. So for your first 10 kilos of body weight, you should have 100 mils per kg. For the next 10 kilos of body weight, so from 11 to 20, it should be 50 mils per kg. And then for anything above 20, you add an additional 20 mils per kg. Okay? So, what did we say Rory's body weight was? 25. Now I'm going to have to get out of, usually I use a whiteboard and I don't have one of those in here. So I'm going to get into Microsoft Word real quick and we're going to go through this together. Maybe, if I can find Microsoft Word on here. I could do a new slide. I don't see Microsoft Word. I don't know how to do a pen. What? How do I do a pen? All these things. Just give me a blank slide. What is this? Okay, there we go. All right, can y'all see this? So, what was Rory's weight? 25 kilos, right? So for the first 0 to 10, Rory's over 10 kilos, right? So we should have 100 mils per kg times 10 kilos. Okay? Right? Everybody see that? So that equals our first 1,000 mils. Now, for kilos 11 to 20, it should be 50 mils per kg, right? And he is over 20 kilos, so we add another 10 there. Right? Jesus, my hands are too cold, I'm sorry. Okay, now, how many kilos do we have left above 20? 5. So that would be 20 mils per kg times 5. Another 100. Right? Does everybody see how I did that? Let me start here. Okay. So then, we're going to finish this one and then I'll get into smaller ones. So then you add all of these up. 1,000 plus 500 plus 100. 1,600. That's a 24-hour order. So then you have to divide that by 24 hours. Okay, so we add up 1,000 plus 500 plus 100, 1,600. That's over 24 hours. So to get your hourly rate, you divide by 24. So you should get an hourly rate of 66.7 mils per hour. Okay, so let's say I have a child who weighs 8 kilos. For the first 10 kilos, I'm doing 100 mils per kg, but I only have 8 kilos here, right? So that child's 24-hour fluid order would be 800 mils over 24 hours. Does everybody see that? Y'all understand what I'm saying when I do that? Okay? So then you would divide 800 by 24 and get your hourly rate. If I have a child that is 12 kilos, okay, well then I've got my first 10, so I need to do 1,000 there. And then how many kilos do I have above 10? 2. So I would do 50 mils per kg times 2 kilograms and get your 100 mils. Does everybody understand that? Aha. Aha. Was that an aha? So between 11 and 20, you multiply that by 50. If it's over 20, you're immediately starting with 1,500 mils, and then 20 times, whatever, however many kilos. Everybody get that? Does it make sense now a little bit? Questions? Let me answer them. What you got?
Can you do the second problem one more time?
So the 8 kilogram one or the 12 kilogram one?
Either one.
So 12 kilograms. You've got a kid that weighs 12 kilograms. So for the first 10 kilograms, you take 100 times 10. After 10, so if you've got 12 kilograms, that's your first 10, right? Well, then what's left on that patient's weight? 2. So then you just multiply 50 times 2. So if they were 16 kilograms, you do your first 10 times 100, and then you've got 6 times 50. They're 19 kilograms, it would be 9 times 50. Anything above 20, it's 20 mils per kg times whatever's above 20. And then at a certain point, you get to adult weight, and it's no longer weight-based. 48 kilos, you're an adult.
For the 25, you did 10 for the first one and then 10 for the second one, and the 5 that was left over, why not add it to the second one? Because it says 11 to 20.
Right.
So why not add the 15 into that?
No. You don't redo the patient's weight. The patient weighs. So for their first 10 kilos, it's times 1,000. For the next 10 kilos, it's times 50. And then for whatever's remaining. So like at this step here, yes. So now I've done 25 minus 10, right?
So you just do 10 at a time, basically.
Yes.
I got you. Because it said 11 to 20, so I was confused.
11 to 20, meaning if they're 18, you're only doing 8 times 50.
Then the 10, and then you do the 18.
Yes.
Gotcha.
Okay. Does everybody understand this? You will need to know this. Okay? I think I say that when it's something important. You will need to know this, yes. When the order is, and your order was to give, I forgot what I told you. Yes, so, right, no, okay, no. This is this calculation specifically is a 24-hour fluid resuscitation calculation. So for this, it will always be 24, okay? So if someone asks you, what would be your patient's maintenance fluid, 24-hour fluid? Yes. No, it's a daily, it's a 24. Does everybody understand that? Okay? If you need more practice, let me know and we could do more practice, okay? For now, let's get into our last scenario. This one's very quick, guys, so let's get back to it. We only have left IM injections. So, maybe y'all don't want to see all my notes. Maybe you do. Who knows? All right, so you're caring for 14-year-old Jackson who has a history of asthma. He's admitted with fever of unknown origin with some respiratory symptoms. You have orders to rule out pneumonia and TB. Y'all know what TB is? There you go. Good job. You need a chest X-ray, an IM fluid, IM influenza vaccine, and a TB skin test. So, you go in to do your assessment. What's part of your assessment for Jackson? Respiratory, definitely. Cardiac and neuro, right? Those are at a minimum if you're doing a focused assessment. Now, I told y'all earlier, with our teenagers, there's other history that we need to worry about, and that includes our Peds assessment. Does anyone know what the Peds acronym stands for? Yes? Oh, is it on the slide? Did I give it to you? Good for me. I'm so glad I did that for y'all. Home environment. Okay, so y'all can read them, okay? Now, obviously, some of these are very sensitive topics. Do you think that your teenage patient is going to just tell you, oh, yeah, I've had sex with 5 partners right in front of their parents? No. So do you think you're going to necessarily ask all of this sensitive information in front of parents? No. No, you're not. And you honestly, in Louisiana, I don't know if y'all are aware of this or not, but children, patients 13 and above have a legal right to private medical information and medical care, especially when it comes to sexuality and anything to do with reproduction. So literally, I need to get my patient's permission to discuss this with their parent or in front of their parent. Talk about a sensitive conversation. Very. So, you may not be asking this on your initial assessment or in front of the parents, but you may need to, and it is uncomfortable, say, Mom, I do have a few questions that I need to ask Jackson in private. Do you mind if we have a few minutes to talk? And if they give you trouble, you say, look, it's understandable that you're upset by this, and I know you want to know everything, but we are providing care for Jackson, and we do need to know what we need to know. And if he's not going to be able to tell us that information in front of you, you know, we need to have you step out. It's not easy. It's not comfortable. It does get a little bit easier the more often you say it and do it. But initially, y'all are all going to be like, I ain't doing it. And I'll tell you right now, most of the time, y'all don't even need to do this as a student. But on admit, or especially if a patient's coming in for abdominal pain or females with issues, you're going to have these conversations. Okay? So, your HEADS assessment would be part of your admit assessment on a teenager. All right, your orders. Let's get back to little Jackson. You need to do X-ray, IM injection, and TB skin test. How do you want to get these done?
Chest X-ray, you tell X-ray, make them get them and take them to X-ray and
you're so funny. You think that this kid has TB, and they're going to go down to X-rays.
Well, it says I need to get one. It's in order.
It is. So how do you do it? So you've got two options. One, Jackson should be placed in what kind of room? Isolation room, right? So one option would be if you need to go down to radiology, Jackson would be wearing a mask. But two, an even better way would be, come on up, respiratory, you put on your PPE and you get a bedside x-ray. All right, so your IM injection and your TB skin test. And you're thinking, well, he's 14 years old, it should be pretty easy. Who are you going to call? Child Life Services. Child Life, are they giving your injections for you? No, but what are they doing? They are distracting Jackson so he can literally be playing his Xbox and you're giving him his injection right there. Okay? So Child Life Services is your friend there. Now, you do need to know. You do need to memorize where you can give injections and the chart that tells you how many mils you can give in each location, when you can start using each location, what length needle, what gauge needle you should be using. There are not many things I tell you you have to memorize, but that and the vital signs, know them. You may see it on any given test this semester, including the final. And if you're in this class, you're taking clinicals, you will be checked off on this. And that's part of your clinical checkoff as well. Knowing your gauge, your length, your volume, and where you can use these, where you can give these injections. Now, some notes to take note of. Your vastus lateralis, where is that? Outside of your thigh, right? You can use that. It is pretty much your primary location for your young kids, right? It's very easy. Once you bend their leg, you will see that muscle. It's a beautiful thing. Right there. You give your vastus lateralis injection there. When can you start using your ventrogluteal? What's the biggest thing? What's the most important thing you need in order to give an IM injection? Muscle. So it takes time to build that muscle. So you cannot use that until they have been walking for a year. So at the very earliest, you're talking 24 months. But that depends on when the kid starts walking. So be safe and just continue with your vastus lateralis. Okay? If you absolutely just love ventrogluteal for some reason, make sure you ask, when did this kid start walking? All right, then you've got your deltoid. You can start using as toddler. It's definitely not the easiest place. It's definitely not the best way because they move a lot. So still, I would say ventrogluteal, but you can start using deltoid as a toddler. And then you've got your adolescence, which you can use any site you want. Okay, but you do need to know. And what does the length? How do you know what length you should be using? Depends on the age, but more importantly, it depends on what do they look like. Do they have big old muscles? Do they have big old fat thighs that you're trying to get through a whole bunch of fat? Don't you love a fat baby? But they got bigger thighs, okay? So I know this is what your chart says, that you're going to be using a 5/8 inch needle, but I got a big old baby with a big old fat thigh like that. Am I getting to the muscle using a 5/8 inch needle? So use your judgment, okay? And do I want to use a 1-inch needle on an arm that's this big and just say, oh, I won't go all the way in? No. Use the appropriate size for your patient. And if you're using a specific size, put it on. You should not see any part of that needle when you are given an injection, okay? Questions about IM injections? Okay, where are you doing your TB skin test? How?
Intradermally.
Intradermal. What's your angle? 15 degrees. 5 to 15. degrees. And what's the point? How do you know that you've been successful with an intradermal TB skin test? Yeah, it's called a wheel. Let's use medical terms here, and you should see your wheel. Okay. All right. That's it, guys. It's not how much you do, but how much you love you put into doing it. Does anyone have questions?
Can you go back to that slide on the fluid resuscitation so I can take a picture of it?
It should be in your. Yeah, y'all should have that.
And I missed the order you said for blood pressure measurement. What was the order?
There's no specific order. It was just those are the sites. Those are your options. No specific order. Those are just your options. Top, bottom, top, bottom. I said the only thing I said was specifically for young kids. You typically see that.
I missed a part of your math for the Tylenol. You just said 5 milligrams per kilogram?
15.
Oh, 15 milligrams? That's why you get 80.
Don't forget to sign in.
So, for the 24-hour thing, if they give you like a 6-hour order for fluids, do you like...
So that's different. No.
They'll just give you what you
So
need.
this is to calculate what would you expect your patient's fluid resuscitation to be.
That's what they want you to have that when they get in there.
Well, so that you can say, okay, I've got an order for 13 mils per hour, but my patient, in order to be actually rehydrated, should be at 25 mils per hour.
Okay, I see. Okay.
So it's kind of like knowing your patient's.
Where's your clinicals at?
I'm at